Okay, sir. So good evening, everyone, and I think we are live now, and so this is a very interesting session, and it took time for us to how to take it forward. I think still this has been a very matlab, we were waiting to have a session, and we got sir because he's busy and so many conferences around. So I will not introduce sir because he doesn't need any introduction. Everyone knows sir, and he was earlier in LV Prasad, like everyone knows, where we started with SLED. And now he's with Shroff Charity Eye Hospital, and he's a director of translational research and innovations. So I will ask sir to inspire us by his journey so that we can take some inputs as in what we can do. Like from some part, maybe we will not be able to replicate entire sir's journey, but we can take some inspiration in some parts. So I think, sir, off to you. On examination is systemic examination is normal, no findings. And when we come to his ocular examination, we are seeing that left eye is essentially normal. It is pseudophakic. The right eye vision is hand movements, no improvement. The vision, the IOP is 20 milligrams. And when we are seeing his left eye, the eye is absolutely quiet. But when we are checking the right eye, so this is the finding. We are seeing that the cornea is clear, but we can see a membrane in the pupillary area. There is a whitish reflex. There is conjunctival congestion and there is mild lid edema. And there is a hypopyon of around 1.5 millimeter, which is white in color. And we cannot see the fundus details. So over to you. What you think? How should we go ahead?
Was that question for me?
No, you can take the question to the audience now.
Yeah, so let's just rewind back to the okay, so let's go to just significant history over here what we have, right? So can anyone tell us what is a significant history that we have? Anyone can just you know uh, tell us what is the most common or what are the red flags that you see in our patient from the history points?
Please unmute and please, Priyansh, you can try.
Post cataract surgery, he's complaining of pain and blurring of vision.
Okay, so would you like to ask anything else apart from this? Would you like to consider, or I would say, onset of pain and blurring of vision? When was it?
Of trauma.
Is it okay? So let's say that a patient comes to you when you know uh, on day or post of day one with such complaints, and if a patient comes to you like in our case 10 days post cataract surgery, uh, can you think of anything that can be different when you have such things?
Post op uveitis.
Yes.
Okay, very good. Okay, so if in that case scenario, once again, what if the patient presents to you in the first week of cataract surgery? Uh, what are you concerned if the patient presents with first week and rest of the first week to 6 weeks per se? Probably, if I have to tell, then probably we can divide the onset of onset of symptoms as immediate post-operative and post-operative day one. You can also have such, onset of symptoms that are very acute in onset, even before 3, 4 days of cataract surgery. Or you can have, you know, onset that is more delayed, as in like 1 week to uh, 6 weeks. Now when we're talking about talking about hand motions, visual acuity, can any of the residents tell me how would you check for hand motions, or how would you check for PLPR uh, in your day-to-day practice, and why is it important?
Yes, Bhavna, please go ahead.
Hello.
Priyansh, I think you are better off
In the
because
presence of bright light at 1 meter distance, we'll check the hand movement.
How it is checked?
Hello. Hello.
Yeah, you're audible.
Okay, finally. Uh,
Hello.
yes, sir. Sir, can you please pardon the question?
So I was saying that how would you check for hand motions, visual acuity, or how would you check for projection of rays or perception of light? And if you are telling something, what do you quote? What study you quote when you are saying that?
So, actually, we can first of all try with the normal visual acuity charts. For example, Snellen chart, we can try for it. And moreover, once we have got the visual acuity with that, then we can go ahead with some. Then we don't need to go ahead with any other option. But if we are not able to get the visual acuity with the currently available Snellen chart, then what we can do is that we can just show the patient the torchlight. If he is able to perceive it, then PL is positive. But to find the correct visual acuity, we will ask the patient to count our fingers. First of all, from 3 meters, then 2 and 1 meter. We
So
can
that is okay for clinical practice, but when we are talking scientifically, there are very well set defined, criterias where someone would say that how would I check for hand movements? Now you are talking about, torchlight. Probably even a torchlight is not the correct answer. So if you go ahead and read back what EVS guidelines, or so when we say about endophthalmitis, our mind first goes to endophthalmitis vitrectomy study. And now we all know the classes on endophthalmitis, so we will think that okay, hand motions, visual acuity, I'll go ahead and it is just hand motions to tap and inject. But based on what? Based on the endophthalmitis vitrectomy study. So apart from these guidelines, they have also given how to check for hand motions, visual acuity, and how to check for projection of rays. And they did not use a torchlight in that. And they had a very specific direction of hands that was moving with a specific background of the room and a specific background of light. Can anyone, if anyone knows, they can elaborate on that.
yeah, anyone in the audience can take. Basically, sir is asking how we check for PR and what is the exact method what was mentioned in the EVS study. What is the standard? Yes, Chaitanya, you would like to take
My
it?
torchlight, yeah. So I would have a different torchlight You will have a pen torchlight, someone will have a mobile torchlight. So does that
Yes,
work?
sir.
Okay, so probably you guys can go ahead and read what is hand motions and what is projection of rays and perception of projection of rays and perception of light based on the EVS. Now, when we go ahead and see the video, now, so let us divide. So there are some few of the clinical signs that are there, few of the clinical symptoms that are there. Now, we touched upon symptoms when we say that, okay, the redness and the decrease in vision was there. And we decided that, okay, if the onset has a very, very useful, it gives the, so the onset of the symptoms, will give us a very important clue that what thing we are dealing with. So similarly, if we go ahead and see the signs, so I guess there was circumciliary congestion, I guess. Yeah. So can anyone tell why would there be a circumciliary congestion and what does it denote? And how do you differentiate between conjunctival congestion?
Priyansh?
Uh, yes, sir. So they just a second. So there was circumciliary congestion in this case, but
No, what sir is asking is why there was circumciliary congestion. What do you think?
so circumciliary congestion in this case might be due to involvement of uveal tract, because in endophthalmitis all these structures are involved, like the ciliary body and including the iris. So there can be circumciliary congestion as soon as it
So when
hello.
we talk about any of the signs and symptoms, every sign and every symptom has a story to tell. And when you understand the story, the science becomes very more interesting, right? So similarly, when you talk about fibrinous reaction or when you talk about hypopion, right? Those has a very clinical significant relevance in our patient also. Now, when you are talking about so you have seen a clinical fundus imaging, right? So once you have a clinical photograph where the patient is post-op, 10 days to 2 weeks, has come with an redness and decreased in vision, and you are seeing that there is an hypopion and fibrin. So what next? What would you like to do in such cases?
So we can go along with the AC tap, although it is not very
No,
specific.
just we have not yet reached to the diagnosis, right?
Yes, sir.
How would how would you make a diagnosis and what would you make a diagnosis?
Sir, the differential diagnosis in this case will include TAS and moreover endophthalmitis also. So to differentiate it, we have to look into the posterior segment. We have to look for the fundus, and for that the fundal view must be available. But as in this case, the fundus was not visible. Then we can try a B scan, because with B scan we can get a general idea of what's going on in the posterior segment. Like if there are echoes, then we can think of any inflammation going on. Moreover, we can think of any vitreous hemorrhage or some pathology like that, which can obstruct these acoustic waves emitted by
So let's
emitted.
stick to our case. So let's stick to our case. So now when we have patient who has a hypopion, who has a fibrin, and it's a post-operative 2 weeks, then you order a B scan. So did you see the B scan in our patient? How was the B scan in our patient?
Yes, sir, I have seen it. As in B scan, we can see there are multiple echoes in the vitreous, which are normally not present. The vitreous is usually hypoechoic. So in this case, we can see the echoes which are in the posterior segment. So we can think that there might be some inflammation going on over there. It may or may not be hemorrhage. The chances for hemorrhage are less because of the
Vitreous
because
exudates are there.
Okay, so basically, if you have an optical, you know, the view of your vitreous is, the vitreous is opacified or the aqueous is the fibrinous reaction is so much that you do not have a view. Even then, in such cases, always try and see in a dark room and, try and see the glow of the patient. Many at times, even if a single, yellowish tinge that you can have in the glow, you can suspect that this can be an endophthalmitis. Because treating a B scan is very difficult. It can be any other echoes, but as you uh, in such case scenarios, see the anterior segment, see the glow of the patient. If the glow is more on the yellowish side, then consider that
And
this can be
mostly
vitreous
there is
exudates.
so we
You know,
find some patients where it is perineal, somewhere some patients it
yeah. So in such case scenarios, you can get a B scan and like in our patients when we are seeing. So can anyone tell what kind of echoes those are?
there are diffuse echoes in this case.
So when we are talking about a reading of a B scan, uh, so their intensity can be, you know, high echoic, medium echoic, or low echoic. There can be dot echoes and there can be membranous echoes, right? So when we talk about B scan, you have to describe in that manner. So what do you think? What kind of the echoes that were there in our patient?
So there are high echoes in this.
So when we say about high echoes, it is compared to what and what amount of percentage do you say it is an high echo?
Uh,
It's
uh,
everything has a value, everything has a reference range. Just a tall spike does not just represent an high echo and not. So let's rewind our case again. Patient post-op 2 weeks, sudden onset diminution of vision, redness, presence with hypopyon, fibrin, opaque vitreous, and has membranous as well as tautic closed, which are diffusely distributed, and probably has choroidal thickening also. So in that cases, what would be your provisional diagnosis for this patient?
so as the posterior segment is involved, it cannot be toxic anterior segment syndrome because in general cases of toxic
See,
anterior segment,
so Priyanshi, you have to think. So
Endophthalmitis.
sometimes the diagnosis is so obvious, you need not to have a differential diagnosis for it, right?
yeah,
So just because if someone is asking you that what can this be, the patient is in front of you, right? When the patient is sitting in front of you, this is so but obvious that you need not to think of task, right? For theoretical knowledge, it is okay. But in this case scenario, there is no other differential diagnosis. Okay, our first thought is, what would be your first thought?
so as the red
Endophthalmitis. What kind of endophthalmitis?
post cataract surgery endophthalmitis.
What kind of post-cataract surgery endophthalmitis?
What kind of oh,
So,
uh, so for that we have to do a
professionally
vitrectomy and
speaking,
take a vitreous biopsy.
surgery. No, 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 no. We have still not completely reached to the diagnosis actually. So when we talk about endophthalmitis, right? Generally, it has been divided into based on the timeline of presentation. acute, and
Chronic.
yeah. So the critical time period over here, what it's generally been decided is 6 weeks. Right now, sometimes what happens is, like what I told you, that even before, the most common presentation is between, like, after fifth or sixth day of cataract surgery and then to 6 weeks. But sometimes you can have and presentation which is even more earlier than the current thing. Some may label it as a fulminant endophthalmitis, right?
Mm.
uh, but in this case scenario, so let's start with just saying that it is an acute post-cataract surgery endophthalmitis. Now, when you have made a diagnosis of acute post-cataract surgery endophthalmitis, let's take a step further in, saying whether this endophthalmitis is due to a virulent organism, or whether this endophthalmitis is due to a non-virulent organism. So, anyone, if we talk about virulence of an organism, so what do you think? What would be signs of an, highly virulent organism, and what would be a signs of an infection that is due to a low virulent organism? We'll get to the point that why is it important to know that, but at least anyone can guess that what are the signs of an virulent organism or an infection that has been caused by a virulent organism.
So the presentation will be acute and
What
virulent.
is acute? No,
Fixed
what is
CZ
acute?
hypopyon.
What is acute? So let's be more specific. I've already spoken about acute and fulminant in that case scenario. Let's be very specific.
So
So let's say, so the first point you were telling is an onset of the symptoms, right? So let me answer it. If the onset is within initial 2 to 3 days, right, it is more likely that the endophthalmitis is due to a virulent organism, right? What is the another thing that comes to your mind? Anyone? So let
Loss of
me
vision.
think. Loss of vision. So if I say the one endophthalmitis is 20/60 vision and one endophthalmitis is an hand motions vision, what do you think? Which is more virulent?
Hand motion.
Exactly. So the poorer the visual acuity, if you have to make it one very objective thing. So if there is only perception of light, this is all based on the endophthalmitis vitrectomy study. They have, published a paper where you can have a, clinical correlationship between the clinical presentation and the microbiology. So they have a paper on that. So when you talk about that, they also say that if the presentation is has a visual acuity of only light perception or worse, then it's an virulent organism. What else? Anyone? Just wild guess. What all things can be there? If you think that the infection is very severe, what all things can be there?
Amount of vitritis.
Okay, amount of vitritis. So what do you think should be the amount of vitritis? So normally, so let me answer that also. Normally, even if you have vitritis, right, there will be some amount of red glow that you can see anywhere in the fundus. If that is not seen, if it is completely yellow and there is loss of your normal red reflex that is seen, then probably you're dealing with a virulent organism, right? What next? So let me give you 2, 3 more points. If the patient, it has been associated with an, corneal wound incisions like corneal infiltrate and all, then probably suggest towards more virulent organisms. So the 6 points that I said was first onset, which is onset of symptoms and sign, which is more somewhere close to even before 2 days of cataract surgery. Initial presentation, visual acuity of perception of light, loss of red reflex, uh, corneal infiltrates, efferent pupillary defect, and you can throw into their cataract wound abnormalities. So in such case scenario, probably you are dealing with an, you know, uh, virulent organism. Nowhere in the discussion there is like if this amount of hypopion or if this amount of fibrin is there, you will say that if hypopion is 1 millimeter or strict hypopion or hypopion does not define whether it's a virulent organism. So now we have made a diagnosis of an acute post-cataract surgery and ophthalmitis in a patient. So I've taught you about these 6 things. Can you probably, Priyansh, say what kind of organism probably we are dealing with? Apply this in our case.
So as the onset is not within 2 to 3 days, so it might not be a virulent organism.
So one step onset, not 3 to 4 days. Okay. Uh, as far as it is the loss of the next step, what perception of light is there? No, it is hand motions. Okay.
That's right.
Then whether it is a loss of red reflex, yes, you could not see any little bit amount of fundus also. Pupillary defect, I don't know whether it was checked or not, and there were obvious, there was no corneal infiltrates. So probably in this case scenario, there is no clear-cut definition or no clear-cut thinking that it is a virulent or non-virulent organism. Why is it important is if you have a virulent organism, if you are dealing with
Hello.
Yeah, I think we have lost audio from Dr. Rudvich. Let's just hold
a
on.
virulent organism, you have to be more the prognosis. Okay, hello, am I audible now?
Yeah.
Yeah, so I was saying that why is it important to differentiate between a virulent organism and a non-virulent organism is, if you're dealing with a virulent organism, in that case scenario, what happens is the, you have to be more aggressive with your management. The prognosis is poor, and you may need multiple interventions in this case scenario, right? So now we have already made a diagnosis of acute post-cataract surgery, endophthalmitis, and the visual acuity is hand motions. Now what will you do?
So just a doubt over here. What kind
Yeah.
of organism it may be? Like you had told about virulent and non-virulent organisms. So what kind of organism this may be in this case?
So it's a very good question. So let me put it like this. There is no clinical sign that can help you differentiate whether you are dealing with fungus or bacteria in acute post or operative or post cataract surgery and ophthalmitis. The only thing what you have to differentiate it is whether it's a virulent or non-virulent. But whether it's a bacteria, whether it's a fungi, there are no clinical signs that will help you to actually say that it is this. Some may say, right, so when you talk about delayed endophthalmitis, some may say it's a, PC plaque. PC plaque hai, so it is Propionibacterium acne. It is like, it is pathognomic of it, but does the PC plaque occur only in P. acne? No,
No.
right? So you cannot close your eyes and say it's a PC plaque. I'll just treat for P. acne and I'll be safe. So in endophthalmitis, from the anterior segment point of view, there are no clinical signs that can give you an clue whether you're dealing with a bacteria or whether you're dealing with a fungi. You can just have a clue whether the organism is virulent or the organism is indolent or non-virulent, right?
Okay.
Okay. So now we have made a diagnosis of an acute post-surgical endophthalmitis, which may be virulent because loss of light reflex and PL vision or hand motions vision. So what next now? What would you like to do? So, okay, before even going to that, what is the definition of endophthalmitis?
So the definition is basically any inflammation which so
which involves the inner coats of the eye with along with the vitreous exudates.
Inner coats of the eye?
All the coats of the eye.
Is it in inner coats or inner
No,
cavities?
so all the coats of the eyeball is involved.
Then what is panophthalmitis?
So actually it is panophthalmitis, but basically endophthalmitis is defined as purulent inflammation of intraocular.
Inflammation of the inner coats of the eyeball with exudation in the vitreous.
So what I have read in American Academy was that it is purulent inflammation of aqueous vitreous.
Okay.
So it is based upon the involvement of the sclera that we see. If sclera is also involved, then we go about a diagnosis of panophthalmitis in that case.
Okay, so now we have touched upon panophthalmitis. Can you enumerate that what would be the clinical signs that you might get when an endophthalmitis is progressing to panophthalmitis?
So there will be severe scleritis. Moreover, there will be circumciliary congestion also, and
Scleritis, what kind of scleritis you're talking?
so diffuse scleritis.
Then? So if you have a patient, so tomorrow this patient turns up and I say there are signs of panophthalmitis, what would you look for?
So in panophthalmitis, all these structures will be involved. Like first of all, starting from the conjunctiva, the conjunctiva will be congested. There will be circumciliary congestion. Moreover, the cornea
That
will
is there
be.
in endophthalmitis also, right? See,
Yes,
lead
sir.
edema, chemosis, congestion, everything will be there in endophthalmitis also, right? So what are the signs that tomorrow I say that the patient is going into panophthalmitis based on what?
Optic neuritis.
How would you judge that?
Sir, based on ocular movements.
Very good. So you check about ocular movements. Then what next? What can be the another marker? So a patient of endophthalmitis, keep checking the ocular movements. If you feel that the ocular movements are starting to restrict, then probably you might be dealing with an panophthalmitis. What next? So let me answer that. So when you are doing a B scan, also look for fluid in the subtenon space. When you have a fluid in the subtenon space, that means your all the coats of eyeball has been involved and the inflammation has crossed the sclera and now has inflammatory fluid in your subtenon space also. Right. Now what next? We still are on the same question. We have an endophthalmitis with, uh, you know, uh, hand motions, visual acuity. What would you like to do?
So maybe vitreous tab to know the nature of the infection and etiology for a definite treatment.
And meanwhile, we can give intravitreal antibiotics.
So for panophthalmitis, we can also look for the T sign in that B
So
scan.
what is T sign? What is T sign?
So it is basically exudative RD.
No, no, exudative RD is not T sign.
T sign is T sign
See,
may there will be a T. So
T sign is nothing but a subtenon fluid. Yeah, it's nothing but fluid in the subtenon space, which I've already spoken about.
So
okay,
there's
so
scleral thickening plus optic nerve involvement. So it forms a T shape in that.
So the T shape is formed by a darkened column of fluid, which is there in the, you know, uh, subtenon space.
Okay.
So
Okay, sir.
normally the subtenon, there would not be any, or you'll find just a normal, isoechoic or hyperechoic bands which are there after the, RCS complex, right? But if there is a fluid in your subtenon space, that fluid will be denoted by a hypoechoic band. Now,
Sir,
if you,
sir,
yeah,
is
just
the sub-tenon fluid a definitive clincher for panophthalmitis?
so very good question. Now let me ask that fluid. From where did the fluid come from?
Sir, the inflammatory mediators, um,
From where? Where?
The sites.
the vitreal.
No, so vitreous is way far. Vitreous, then you have the retina, then you have the choroid, then you have the sclera, then you have the
So
subtenon
from
space, then you have the tenons, right? So
Yes,
so
sir.
when you're talking about endophthalmitis, where is
sir,
the actual site of infection or inflammation?
sir, in panophthalmitis or
Sir,
endophthalmitis.
the retinochoroidal complex.
No, it's in the vitreous, right?
Yes.
Vitreous
Okay.
is, it's in the vitreous. When we're talking about endophthalmitis, or in the, I would say, let's not just talk about vitreous, in the ocular fluids. Okay.
Okay, sir.
Now, when we are talking about ocular fluids, panophthalmitis means the infection which was initially just related to the cavities has now been involving the whole of the coats of the eye. The outermost coat is what? Sclera. For sclera to be involved, the inflammation should cross all the barriers, retina, choroid, and then sclera. And once the sclera is involved, then and then only you can see an exudation from the sclera, and then only anatomical space that is available, okay? Or probably I would say two anatomical spaces that are available. First, you can have a choroidal thickening and choroidal detachment. The next space that is available, right? When you have a suprachoroidal space and you have a subtenon space. So fluid can accumulate in front of the sclera, fluid can accumulate in back of the sclera. When it accumulates in front of the sclera, you can have a focal choroidal thickening, you can have focal choroidal detachments. If it accumulates behind the sclera in the subtenon space, then you see as an hypoechoic line, which denotes, so hypoechoic line with an optic nerve at the center. So this is your optic nerve. From there, a hypoechoic line will come. So if this is your optic nerve, you have a B scan or a cup like this that is done, right? B scan and cup is like this.
Sir.
So hypoechoic line from here and here, that is due to the subtenon fluid, will form a T. That is nothing but your T sign.
Okay, sir. Thank you, sir.
Sir,
Right?
is T sign also seen in posterior uveitis? If there is only posterior uveitis.
See, it generally denotes that there is inflammation of the sclera, right? That inflammation can be infectious in cases of your endophthalmitis. It can be non-infectious when you have a posterior scleritis. Even when you have a tubercular granuloma, you can have, uh, you know, fluid that can go. So tubercular granulomas, they are in the choroid. So all the adjacent structures can show fluid in such cases, and it is not rare to find, subtenon's fluid even in tubercular granulomas also. So infectious or non-infectious disorder, it just denotes that your inflammation has reached up to the sclera. If you have a T sign or so T sign, you'll not have T sign in all the patients because to form a T, the subtenon's fluid should go to the optic nerve head. That may not be the case in all the patients. So in such patients, you may have a localized subtenon's fluid anywhere in the globe. So it nothing but denotes the inflammation of a sclera. Yeah, so what next? What would you like to do? So someone had said, Dr. Swati had said that vitreous tap and vitreous antibiotic injections. So this is very important because if you become a retina surgeon or if you do not become a retina surgeon, you are in first ophthalmologist. The most dreaded complication for anyone to have is an endophthalmitis. So in that case scenario, you should be able to manage at least primarily uh, case of an endophthalmitis before referring to a retina specialist, right? So let's consider a setting where microbiology is not available, right? Then what will you do?
So can we give antibiotic and antifungal? Both.
Okay, so when your microbiology, so who answered that?
Sir, I did.
Okay, Rohan.
Rohan.
So Rohan, what antibiotics or what antimicrobials would you like to give?
Sir, vancomycin and ceftazidime.
Okay, this is based on what and why?
For both
Just
gram
give me,
positive and gram negative coverage.
just give me 1 second. I'll just grab a bottle of water, please.
So basically, what Dr. Rudvij was talking about T sign is that T sign is suggestive of posterior scleritis. So if in any case, whether it is endophthalmitis or as Dr. Rohan asked, whether there is uveitis, if you see a T sign, that means the sclera is involved. So in a case of endophthalmitis, which is primary involvement of vitreous and maybe retina, you are having T sign. That means the infection has spread up to the sclera. So now this is a case which is going into a panophthalmitis and the management and the prognosis changes. So hence what Dr. Rudvich was emphasizing is that we have to look for the T sign even in cases of endophthalmitis so that you are not missing early signs of panophthalmitis because the prognosis changes if the endoph is going into panoph. Yes, Dr. Rudvich.
Okay, sorry, I was unmuted. So Rohan, why is it so?
Sir,
So when we,
based on
this is based on what? Yeah.
EVS, maybe.
So when we are talking about empirical therapy, right? Empirical therapy means you do not know the organism. So what if it's fungus? What will you do? So in that case scenario, you should actually know that what are the most common organisms, that causes acute post-operative endophthalmitis, right? Because, can anyone tell me what are the most common organism
Sir,
that causes acute?
Staphylococcus aureus and epidermidis.
Epidermis.
Both are gram-positive bacteria.
So coagulase negative step. Yeah. So coagulase, yes. So let me just put it in that way. 90% of patients, 90 or I would may say 92% of patients, right? You'll have bacteria as the causative organisms for acute post-operative endophthalmitis. Fungus constitute only a very small amount of cases of acute post-operative endophthalmitis. So there lies your science or signs why you want to give just vancomycin or ceftazidime or imipenem or whatever. Why just an antibacterial cover and why not an antifungal cover that needs to be given empirically? Each and every statement and word is important. We are talking about empirical usage of antibiotics. When we are talking about empirical usage of antibiotics, uh, it is based on the most common organisms, and that happens to be bacteria in cases of acute post-surgical endophthalmitis. So why vancomycin? So next question, why vancomycin?
Acts on gram-positive bacteria.
There are many drugs that acts on gram-positive, right? Why vancomycin?
So it
So if
also
you
acts on
add
MRI.
why, how, when to any of the things, right? So let me give you one tip. Add why, how, what, when in all of the settings. So whatever you see, whatever you think, add a question why, how, when, what to any of the things, and the signs become more interesting. Why vancomycin?
So because it is drug of choice for MRSA, methicillin resistant Staph aureus.
We have
Broad
uh,
spectrum antibiotic.
okay.
Broad
So
spectrum is ceftazidime.
no, ceftazidime is a different ballgame. Let's stick to first vancomycin. So when you talk about an empirical line of drug, right? The thing is, it should cover the most common organism, and most common organisms should be susceptible to them, right? So let me repeat the sentence. It should cover the most common organisms, and most common organisms should be susceptible to them. So vancomycin is a broad spectrum antibiotic against gram-positive organisms, and close to 97 to 98% of organisms are sensitive to vancomycin. So when we talk about vancomycin resistant species, those are very rare, right? So there are species like if I have to say Enterococcus, right? Enterococcus, some of the species, they will be inherently resistant to vancomycin, but those are very odd case scenarios. So somewhere close to 97 to 98% of gram-positive bacteria are sensitive to vancomycin, right? So the science behind choosing vancomycin is just not broad spectrum. So it is a broad spectrum, but all the spectrum are still sensitive to it. So what about ceftazidime? What is ceftazidime?
It is third generation cephalosporin.
Okay, it's actually active against what kind of drugs?
Gram-negative.
So, gram-negative bacteria are very notorious in a way. So if I have to tell you, those are such bugs that, they tend to alter themselves in every possible way that is, there in literature or anything.
Null and void क्या होता है?
Why is this important is, on the contrary to vancomycin, when we say that the uh, gram-positive bacteria are, close to 97 to 99 percentage, sensitive to vancomycin, there is high resistance to ceftazidime. So the EVS, so why ceftazidime on based of what? Can anyone tell me?
Ceftazidime.
So let me put it in this way. When we talk about endophthalmitis, the management is generally based on the EVS study. If someone is speaking, I cannot hear. So when we are talking about endophthalmitis, we talk about its management. It is according to the EVS study. But you have to take the results of EVS study with a pinch of salt in today's scenario, right? EVS did not look into ceftazidime, it just had an amic acid. Over the course of time, they visited that data, and they said that cefta may be an alternative, but it was never a proven drug. Yeah, vancomycin and amic acid, agreed. But over the course of time, right, in our studies also we have found that resistance to ceftazidime has been increasing. As a clinical practice in our campus, we have shifted from ceftazidime to imipenem as our first line empirical therapy towards gram-negative organisms. In probably 1 or 2 years, we are coming up with an even larger study called as the Endophthalmitis Management Study, which was started somewhere in the late 2020 and early 2021, which was there to challenge the EVS study, because the management of endophthalmitis is still driven by a study that was done in 1995. So in our interim analysis, ceftazidime has still been, there are somewhere close to 40 to 50% of gram-negative organisms that are resistant to ceftazidime. So in today's date scenario, we have shifted from ceftazidime to imipenem, and probably in our if our results are out, so we have been recruited somewhere close to 398 patients in our EMS study, but we still have to include 40 more. So in that cases, even we have tried colistin as our primary drug, because the resistance to ceftazidime and imipenem is also increasing. So last common what I would say is, in such cases scenario, vancomycin is still the drug of choice again gram positive, and gram negative we still have to take ceftazidime with a pinch of salt. What else could you give in such patients of an acute post-operative endophthalmitis?
The
So,
azoles like voriconazole.
so Dr. Swati, I just explained that the choice of empirical therapy is based on the most common organisms. When fungi is not even very close to even 10% of my cases, the choice of an empirical therapy would not be, covering antifungals until and unless my microbiology says that, I have a fungal isolate that is there,
Okay, sir.
especially for acute post-operative endophthalmitis. We are talking about here just acute post-operative endophthalmitis.
Yes,
Not
sir.
extrapolate EVS or whatever I'm saying to any another form of endophthalmitis. We are just strictly restricting our discussion to acute post-cataract surgery endophthalmitis, right?
Yes, sir.
So now, what are the role of steroids? Can anyone tell me what are the role of steroids in such patients?
Yes, Priyansh.
Uh, So in bacterial, there will be no role,
Okay.
but
So in which conditions would you like to give steroid? If not in bacterial, then yes, we have Dr. Rutwij.
Yeah, sorry, I had a call. So basically, when we are talking about steroids in our clinical practice, in a setting of, you know, uh, acute post-operative endophthalmitis, you have to think of two things to treat. First is infection, second is inflammation, right? The most easiest part to treat is inflammation. It's just steroid. The difficult part lies in treating the infection,
But
right?
sir, would that not flare up the infection in the cases where it is extremely virulent?
No, so that is what is virulence? So if I talk about an organism, right, what defines virulence?
the ability of organism to evoke an immunity response.
Exactly. So virulence will also depend upon the amount of capacity of that organism to induce an inflammatory response, right? So only and only when you have a fungal isolate, right? And intravitreal dexamethasone. So let me put forward more pharmacokinetics that you may understand. When I'm saying that I want to give intravitreal dexamethasone in all of my patients of acute postoperative endophthalmitis, there is a science behind that also. The pharmacokinetics is first science is fungus is very rare in acute post-surgical endophthalmitis. That is first point. Second point, the half-life of dexamethasone in the vitreous cavity is somewhere close to hours, not even days. We are talking about hours. So even if I give dexamethasone today in the vitreous cavity, it is not going to last and cause the effects that we think that okay, the deleterious effect of the fungus if you give a steroidal injection in that case scenario is not going to happen first. So the points what we have is we have to treat the inflammation also, because many a times what we say is if we have to say why or how much percentage of patients in EVS did not have good visual acuity. With good visual acuity I mean to say 20/60 or 20/40, greater than that, right? The most common thing what they had was macular toxicity. Why was macular toxicity seen? There are two or three insights that can be given. One is an aminoglycoside related macular
Gentamicin.
toxicity, or other is yeah. So aminoglycoside related toxicity, or they never did a complete vitrectomy. In that age scenario, it was just a core vitrectomy. So when we are talking about core vitrectomy, the posterior hyaloid was not separated. So the vitreous is still attached on the retinal surface. So there is inflammation and infection that is still on the retinal surface, which is causing destruction in the retina, right? So that is why in patients of EVS, the success or visual out equity outcome was never greater than you know uh, 20/60, 20/40 in patients. Somewhere close to not even 50% of patients achieved that, right?
Mm.
So treating inflammation in so I'll repeat myself: steroid intravitreal dexamethasone is used in all cases of acute post-surgical endophthalmitis as an empirical therapy. I'm talking about. I'm not talking about. So if microbiologically proven bacteria, still you'll give steroids. Only when there is a microbiologically proven fungus, right? You will not give a dexamethasone. Another thing what I would like to say is what are the role of oral or systemic antibiotic uh, so
Systemic aspects.
yes. Do you think those are helpful?
There is no role of systemic.
It is
So,
helpful in endogenous endophthalmitis.
so now again, let me tell you that whatever you are quoting is very ancient. We are talking about studies that has been done in 1995. Probably some of you might not be born during 1995, if I'm not wrong. Many of you will not be even born when the EVS was done, right? So that age-old study, they had different kind of uh, antibiotics, and the route of antibiotics were way different to what you have right now, right? So we do have studies where the newer generations fluoroquinolones have a very good penetration in vitreous. So in an acute post-surgical endophthalmitis setting, we do give ciprofloxacin 750 milligrams twice a day in our patients, and it has been shown to be effective, and it has been shown that that given amount of fluoroquinolones do reach the vitreous cavity in a concentration that may be equivalent to the MIC of many bacteria. So if I have to just break down the management: empirical therapy, gram positive vancomycin, Gram negative, the jury is still out, but ceftazidime is very, very old. We have shifted to imipenem probably in the due course of time 1 year when we are out with our results of our EMS study. Probably colistin can also take over. Dexamethasone in all cases of acute post-operative endophthalmitis, which are not culture proven fungal or microbiological proven fungal. In all cases, dexamethasone are given. Why given? Because fungal are not common organism in an acute postoperative settings, and dexamethasone has a very short half-life. And oral antibiotics, we do give fluoroquinolone, 750 ciprofloxacin PD, right? Uh, I think we should not go into complete vitrectomy and core vitrectomy. What do you say, Dr. Anuj? I've just touched upon them, but
So I think this is the main what you have discussed is very important. So there were just few questions. I think if we can take that. So
sure.
the other forms of steroids, uh, topical and oral. So what is
Right.
your
So topical steroids is like what I said. Generally, we give topical steroids in all our patients. So oral steroids, the need for or when would a need for an oral steroid arise? We generally give in our all our patients of you know uh, I would say an acute post-surgical endophthalmitis dexamethasone. So if at all I want a longer coverage of inflammatory action, anti-inflammatory action, then also probably I would still go ahead and give an intravitreal triamcinolone. But this comes with an star mark or an asterisk marks conditions applied. Okay. When I say that, you know, uh, I'm talking about giving an intravitreal triamcinolone in patients of endophthalmitis, you have to understand that three criterias, right, should have been fulfilled. First criteria is that you have already identified the organism. It should not be that microbiology has not identified an organism and you are giving a long acting or a depot steroid. Okay. Second thing is even after the organism is identified, right? The organism should be sensitive and should have good response to your prior injected antibiotics because an in vitro scenario and in vivo scenario can be different. So first thing is it should be susceptible to the antibiotics that you have given. And the third thing is even after susceptibility, priorly when you have given an intravitreal antibiotic as well as dexamethasone combination, it has responded. Then and then only we can go ahead and inject a longer acting, steroid like a triamcinolone.
So can you please repeat the third point?
So let me again repeat it. Longer acting steroids like a triamcinolone, you use only so when you put three tick marks. First tick mark, whether you identified the organism or not. Second tick mark, whether this identified organism is susceptible to the antibiotic that you have given. And third tick mark, that after you have already given the susceptible antibiotic injection plus the dexamethasone, there is clinical improvement that is noted. Okay, it means
Yes.
there has to be a good response to the prior. Then and then only you think of giving and longer acting triamcinolone.
So, I have a doubt over here. Like in American Academy, it is written that few anti-VEGFs and intravitreal triamcinolone can also cause intraocular inflammation. So, how how can we know whether it is safe? Because there is a lot of information already in case of endophthalmitis. So,
No, we are
is
not
there any
talking about an anti-VEGF, right? We are just talking about a steroid. We are just
yes,
talking about steroids.
yes, if it is written for triamcinolone also that intravitreal triamcinolone sometimes cause intraocular inflammation. So how can we assess that whether it is safe or
No,
not?
no. So probably it cannot be due to the triamcinolone. It may be due to the another, carrier molecules or anything. But I don't know about such kind of responses. Probably I'll have to go and read about that in literature. That IVTA induced inflammation. Uh, probably it would not be due to the molecule. It can be due to anything contaminated or kind of an preservative. But so for that case scenario also, when we talk about injecting and triamcinolone, there are multiple formulations that are available. You have an IM injection, you have an IV injections. So you cannot inject an IM and IV injection inside the eye, right?
Yes,
So there, no, it has been practiced. If you go outside, you check your hospital. If someone is given a PST injection, it will be an IM or an IV injection that they might be using. So what brand you are using? Canacort. Canacort is used for IM or IV use only.
no, sir. Over
Right?
here we are not using Canaccord, but I have read it in iWiki that intraocular inflammation can also be due to triamcinolone or other anti-VEGFs. So I just wanted to clear
But
that point.
triamcinolone is not an anti-VEGF.
Yes, sir, it is not an anti-VEGF, but yeah, they have written for triamcinolone also, but they have not explained that. So
So
that was
probably
my
you
concern.
can. So if you can just mail me or something, I'll get back to you after searching in literature. I am not aware of it. I may have to read literature, go back and read literature for it.
Sure,
So
sir.
topical steroids are indicated.
Yeah, in all patients, if there is no microbiologically proven fungal, empirically in all patients.
Oh.
Okay, there is a very good question. Can we repeat intravitreal antibiotics? Right. So even before that, TAP versus vitrectomy. So in that case scenario where the viewing systems were very bad, and even so, if we go just rewind yourselves to 1980s or 1970s, the era was of open sky vitrectomy was there. So in that case scenario, the vitrectomy machines and the vitrectomy viewing systems were still not developed. So in that case scenario, they just did a core vitrectomy. But let me give you an analogy. So if in your body, if you have an abscess, what's the treatment for it?
Drainage, incision and drainage.
Drainage. Exactly. Right. So consider that it's an abscess inside your eye. So the more amount of vitrectomy, including removal of posterior hyaloid, you can do, right? It is more beneficial to the patient.
So there's a
So in
study
that
called
case,
as CEV, na, complete endophthalmitis
exactly
vitrectomy.
complete early vitrectomy in endophthalmitis.
Yes.
It is from the ESCRS group. Yeah, that is what it is, right? So CEV study will tell you that it is basically because the visual acuity that has been reduced because of the toxins that are still there on the macular surfaces, because you have not removed the hyaloid, only core vitrectomy is done. That's why. So in this case scenario, given a choice, every vitreoretinal surgeon in this case scenario will love to do a complete vitrectomy.
So what should be the sequence of the steps of management? Like, should we go on with vitrectomy first and then give an intravitreal injection, or should we do the reverse?
Very good question. So let me give, if you have a retina setup, if you have a micro, yeah, let me answer that. So if you have a retina setup, you have a retina backup, always, first thing is an undiluted vitreous sample, right? Even if you're doing a vitrectomy, whether you're doing a vitrectomy, whether you're not doing a vitrectomy, undiluted vitreous sample is the first thing you do. And it's not a tap. What we do is a vitreous biopsy. because initially what times if you inject a 26 gauge needle and just take it out, if the X-rays are too thick, you'll have nothing and you'll just say it's just a dry tap. Okay. And so in that case scenario, vitreous biopsy is required. You go with a cutter. The cutter aspiration port is attached to a 2 cc syringe. You start cutting, tell your assistant that she aspirates or he or she aspirates slowly. Then tell your assistant to stop and then you stop cutting. This is how you take a vitreous biopsy, come out from a single port. Then if you're planning, if you have a backup for your, retina colleagues are there, probably the decision is theirs whether they want to do a complete vitrectomy, whether they want to do a core vitrectomy, whether media provides and all. So in that case scenario, then vitrectomy and then give, you know, uh, antibiotic injections. Now, few of the other questions what I'm seeing is when do you repeat an intravitreal antibiotic injections? It's also very big topic, probably the time constraint. I'll have to just simplify. It just not depends on, clinical response. It depends on whether your eye is vitrectomized or non-vitrectomized. It depends on whether your eye is phakic or non-phakic. It depends upon, the half-life of the drugs. Half-life of drugs depends on whether it's a cationic drug, whether it's an anionic drug. Because what happens is some of the drugs can have, uh, you know, uh, those are thrown out from the eye just from the anterior segment. Some of the drugs are thrown out from the posterior segment. Some of the drugs are thrown out by both, right? So there are multiple things in this. But generally speaking, when you have an just non-vitrectomized eye and uh, the response to the treatment is status quo or it is worsened, you repeat the injection after 2 days, 2 to 3 days, 48 to 72 hours in a non-vitrectomized eye. That also depends on the T half and what drugs you are indicating. So, you know, say some analogies like fluoroquinolones, excellent drugs. Those are excellent drugs with excellent coverages. But in vitreous, half-life is 4 to 6 hours. That's why you have not seen that, moxifloxacin is not injected in the vitreous. You don't hear like that, right? Because their half-life is just in hours. So vancomycin, 48 to 72 hours, ceftazidime, 48 to 72 hours, imipenem, ceftazidime, 48 to 72 hours in a non-vitrectomized uh, phakic, or I would say where the posterior capsule or the lens is still intact. Next thing, when we talk about antifungals, this is where our protocol little bit differs from what it might be practiced elsewhere. Uh, See, we have published data on that also. In that case scenario, generally amphotericin B, they say that you repeat every weekly. That is what outside it has been practiced. But what we have done is we repeat half dose of amphotericin B after every third day. So what would that help us to do is maintain a very high concentration of amphotericin B throughout the course of management. And we generally combine amphotericin B with voriconazole because of the synergistic effects. So elsewhere, they will either give voriconazole, either give amphotericin B, but we have our published data also on that both the drugs given, simultaneously helps and works synergistically. How early can we start
Sir,
topical steroids if we don't know
when should we follow up the patient of an intravitreal vancomycin and ceftazidime injection? And what investigative modality should we use? Should we just follow them up with serial B scans and note the?
So, so let me put it this way. Do you diagnose glaucoma on HVA?
No, sir.
Similarly, endophthalmitis is not diagnosed based on a B scan.
Yes, sir.
So,
So, sir, what are the main features we
yeah.
should be looking at on the
So
follow-up?
never
Visual
ever
acuity.
in your life, never ever in your life discount clinical examination. Rescan and your all the other modalities are there to aid you, but not replace your clinical examination. Okay.
So, yes,
So
sir.
you start even with symptoms. You ask the patient, how is your pain? Right? If the infection and inflammation is getting under control, he'll say, Doctor, no, my pain is reduced. Right? So you start with the
Yes, sir.
symptoms. You ask the patient, how is your pain? If the vitreous is clear, I'm completely vitreous, he'll say, yesterday I could not see anything. Today I can just see that, okay, your hand is visible or I can see your shadow,
Yes, sir.
right?
So, an
So
improvement in the vision.
each and every sign which
Yes,
was there for diagnosis of endophthalmitis should be rechecked again,
compared.
right?
Yes,
Right from be it congestion, be it lead edema, be it cells in the AC, be it flare in the AC, be it your vitritis, be it your yellow glow. Then next you go to the fundus, you see whether disc is visible, whether your first order vessels are visible, whether your second order vessels are visible. If nothing is there, then you go ahead and do B scan.
yes, sir.
So B scan never ever replaces you. It aids you. Don't be a doctor that, you know, I would say treats the investigations. Rely on your clinical knowledge.
Yes, sir.
IOL have to be explanted in cases of fulminant endophthalmitis along with vitrectomy. No, not in first case scenario. Always, you should have a stepwise approach.
So in cases where we do not have a retina setup and an endophthalmitis, we are having the hypopyon. So can AC type helps us?
Right? It can help us see. You have to think that vitreous is more fertile for organisms to grow. It can help you. That is okay. But at the end, if you're not going to manage it, best thing what you can give in an acute post-operative endophthalmitis, what you can do is, if at all microbiological setup is there, you take and tap and you send it. If not, just give an antibiotics and refer to your colleague who can handle it more, in total.
Okay, sir.
So what you can do is give an empirical therapy like what we have just discussed and send it. Probably I have not discussed about the risk factors of endophthalmitis, but probably then it becomes a very long classes. But that is very important. So when do you think another important factor we have not yet touched upon is endophthalmitis prophylaxis in cataract surgery and all. But then it becomes a very, very large topic. Do we have time for that, Dr. Anuj?
It's totally your class and the students.
Okay. So
I think maybe
just
we can plan another session, or if you are comfortable, as between you and the audience.
so let's just quickly touch upon some parts of prophylaxis, right? So rather than who probably a senior resident any of you can tell me how cataract surgery is done in your hospital, or and just stick to, I would say, to prevent endophthalmitis, nothing else. What should be done, or what you have seen being done in your hospital?
The sterilization of the instruments in autoclave. Moreover, there is fumigation of.
That is standard. Just let's just stick to in the operating room or in the
Sir, an
operating campus.
intracameral injection of moxifloxacin.
Okay.
Installation of eye drop.
What eye drop?
betadine eye drop before the surgery.
5% povidone iodine.
Right. Okay. So next, first, the most important one thing, 5% povidone iodine in the conjunctival cul-de-sac before you operate. Next, is there any role for
Sir,
preoperative
some
antibiotics?
some people say that eyelashes should not be trimmed because the
Should be
flora
trimmed.
can fall onto the on the eyelid surfaces, so like it can cause endophthalmitis. Like some studies say that we should not trim and some says that we should trim ideally.
So
But sir, if we
let's
put the
simplify
drape
to a
properly,
point.
then the eyelashes don't really fall.
Let's no no let's simplify to a point is whether you cut or whether you do not cut, the lashes should not come and touch your operating field. Okay. If you cut it, it should not touch it, let it go out, cut it outside of the operation theater, then paint and repeat and do everything. Because in my cases of a retinal detachment, when I have to place a belt buckle, I cut my lashes. In the sense, in patient's lashes. Because I don't want a small cilia going behind inside the subconjunctival space and then causing inflammation or infection over there. So we would not do that. So let us just say that it is just the lashes should not touch the surface, whether you cut it or not, it's a personal choice. Okay, Laplace and thorough examination to rule out corneal infiltrates, periocular infections. So the risk factor over here is Laplace or blepharitis or diabetes or on that case scenario. One common find, if you are doing a syringing test or Laplace the same day, never ever perform your cataract surgery.
Yes, so the contact procedures are better avoided right before the
It's
surgery.
not about contact procedures. It is about,
Syringing.
syringing or, any of the lacrimal procedures should not be done on the day of your surgery. Then
So why?
you are irrigating the surfaces. Everything that is there inside your lacrimal sac will come in your conjunctival cul-de-sac, right?
Yes.
Then, so let us just divide preoperative, intraoperative, postoperative, right? Preoperative, what we generally like to do, right? We do not use preoperative antibiotics. We rely on our sterilization and our antisepsis very heavily. So in that case scenario, antisepsis starts even before the patient has been in the OR complex. You put up 5% povidone iodine drop when the patient is in the OR complex. Then you again put povidone 5% povidone iodine after you block the patient. Then the surface is cleaned with a 5 to 10% povidone iodine in such a way that you do not strike the same area twice, and it should be so many of the people they say, some say medial to lateral, some say lateral to medial. The only thing is scrub your lashes also. Do not repeat it from one side to the another side. The next thing what we do is intraoperatively. Uh, there are few reports that we dilute the povidone iodine. We dilute it to a concentration of 0.25 percentage. And when you and frequently irrigate the surface of the eye with that povidone iodine when the surgery is going on. Uh, Caveat over here is when you irrigate with 0.25 percentage, if you irrigate multiple times on the cornea, intraoperative, you can have superficial punctate keratitis and your view can be, distorted. So in that case scenario, when you're using that, it should not touch the cornea. It should be just around the cornea and on the conjunctiva, and it should flow off sideways. There is 0.25 percentage. Then intraoperative, another thing is intracameral antibiotics. There are multiple intracameral antibiotics that have been used, cefuroxime, moxifloxacin, vancomycin. However, due to the reports of HORV, hemorrhagic vasculitis, post vancomycin is no longer used. You can either use cefuroxime or you can use, in that case scenario, moxifloxacin. Cefuroxime can be given in 1 milligram per zero point 0.1 ml. So zero point 0.1 ml of drug can be injected. Similarly, 0.15 milligram of moxifloxacin. Mind you, these are all preservative-free drugs, can be injected at the end of surgery intracamerally. After that, before even patching your eye, we put a 5% of povidone iodine. And
Bone
post-operatively,
should be hydrated properly,
yeah, so
like leaky pneumacy.
exactly. So surgical point of view, then in that case scenario, you should not try to finish the surgery early. You should not have extensive manipulation. You should not have PCR. Your wound should be good. There should not be leaky. If you have vitrectomy, the vitreous should not touch your ports. That all things needs to be there. Uh, Post-operatively, we give antibiotics just for 1 week. Our protocol is occupol, that is 4 to 6 times a day for 1 week post cataract surgery. All the restriction, head baths, no water in the eye is just for 2 weeks post cataract surgery. This is what we follow.
Sir,
Anyone has any doubts?
should cautery always be done, or can we close the wound by subconjunctival dexamethasone and gentamicin?
Very good question. Generally, we do not. So, as a clinical practice, many of you might be giving dexamethasone over the conjunctival flap, right? Uh, in our experiences, giving a steroid at the site of your incision may predispose to endophthalmitis. So even if we are giving a gentamicin or dexamethasone, it is not at the site of uh, you know uh, your incision. It is in the inferior fornix.
So can we give the same conjunctival injection of Genta and Dexa in any other part other than the um, like conjunctival flap or the incision site like side port?
No, nothing in the side port apart from antibiotics. If you want to give, you can give a transeptal, like what you give like a block, right? You can give dexamethasone like a block.
No, sir, I was asking about like what in
Hydrating your
our
ports with
not that, sir. Actually, in our hospital, what we do is that after completing the SICS, we give the injection of Genta and Dexa subconjunctivally from opposite to the side of side port. Like if we are operating on the
Yes,
right hand.
what he means, I have also seen some of the seniors doing the same. It actually, what they say is it creates a very good sealing effect. So after hydrating the side port, they kind of put the subconj dexamethasone opposite, right, adjacent to the side port as well.
So that's what I said. We do not practice giving anything close to the incisions, right? The sealing effect, if you just have a good incision, it will seal, and if you hydro, it will seal, right? If you want to say, so if you go into the science behind it, so if you hydrate a wound, how much time does the hydration effect stay? Have you thought into it? How does a cataract surgery incision, you know, close? Have you thought on that?
So the stromal edema, which is induced iatrogenic.
That next day, do you see edema?
No.
No,
No,
sir, it
sir.
resolves. It's totally
Then
clear.
exactly, right?
Hmm.
So
Moreover,
whenever you are seeing a sign, right? Whenever you are thinking a sign, if I am saying or if anyone is saying, don't take that on their face values. You have to go back and read about the science behind it. Do you think there is a science? If you give a subconjunctival thing, you'll have a closure of your side. But do you think it is? They may say, but do you think it's logical? Is it backed by your science?
No, sir.
no, sir.
But sir, if
Exactly.
you give superiorly, it can cover the tunnel, and
If
when like you need not to
you
do the
you if
cautery.
you can just iron it out. You can just iron it out if you don't want to do surgery.
Okay.
What do you do? So when you're doing a pterygium surgery, right? If you're not using a glue or so, is it necessary for you to actually put sutures?
No, sir. Autologous can also be done.
Then
Hmm.
then why can't you do with this?
Yes, sir.
So the only thing probably I would like to say to all of you is think, think, and think. Why this? Why this? Question. Everything should raise a question. If you are doing this, is it correct? Is he speaking? Even you can question me. I'm not saying whatever I'm saying is wrong. It is best of my knowledge, right? So you question, you counter question, try to find the answer, try to find science behind the things. Modern day medicine is an evidence-based medicine. It is not that in my experience, I want to do like this and I'm doing like this. It has to be an evidence-based medicine and everyone has to practice accordingly. Then and then only you're a very good practitioner.
Yes, sir.
Okay, probably it's getting too late, Dr. Anuj. If anything, you guys can reach out on email
So I think there'll be lots
or
of questions and but it has really been an amazing session and really because we have stressed on simple things, not going too much into that, but stressing on the basics. And I feel that we will have a lot more better management of end off from starting tonight only. And
yeah,
so we will catch up with Dr. Rudvij whenever he is free for another session. And it was
yeah.
really nice for you to spare
So
time and take up this
thank
topic.
you,
And
Dr. Anuj. So let me just summarize very few learnings, right? A diagnosis of endophthalmitis is always clinical first, aid with rescan, diagnosis acute versus chronic, acute if you have that vitreous biopsy versus vitrectomy, empirical, we touched upon empirical therapy, vancomycin, choice of vancomycin and gram negative. Then we touched upon dexamethasone. Then we touched upon orals, and then we did touch upon when do you repeat intravitreals, and finally we touched upon the risk factors and prophylaxis. So probably try to cover everything, uh, even if you take 5 to 10% also, but take it and do read it. If you read it more, question each and every sign. Every sign has a thing to say. Every symptom has a thing to say. You know, a doctor which Dr. Anuj, you'll be knowing you are an ex LBPI guy. 3H is what we talk about,
right.
right? If you have the 3 H's, then you are a very excellent doctor.
So and thanks Priyansh for presenting the case. And so I think we'll just wrap it up now and we'll catch up with Dr. Rudvij and everyone for another session, maybe on some other topic. Okay, so let's
Thank
relieve
you so much.
everyone.
Thank you
Okay.
so much, sir.
Thank you so much, sir.
Good evening, sir.